Hello everyone. I am myself Dr. Rajesh Gubba. I am the General Medicine educator. So I welcome you all to this daily quiz discussion on my Telegram channel where I am conducting the medicine challenge for 50 days, and as a part of it on day 10 we have done a grand test on connective tissue disorders and as well as the topic of cardiology. Let me discuss those questions now. So the first question is, a 75-year-old woman presents to her family physician with a 24-hour history of rapid irregular palpitations accompanied by fatigue. In an elderly patient, what is the most likely cause of the palpitations? Atrial ectopic beats, atrial fibrillation, supraventricular tachycardia, ventricular ectopic beats, ventricular tachycardia. So, the point which is given here is the irregular palpitations. That is one point, and second important point is the elderly females. So in elderly women with irregular palpitation, the most common arrhythmia that would be responsible is the atrial fibrillation, right? Whereas you take in case of the atrial ectopic and as well as ventricular ectopic, even they also cause the irregular pattern of the heartbeat, but usually, not always, but usually it is regularly irregular type of rhythm, whereas in case of the atrial fibrillation it is irregularly irregular rhythm. In supraventricular tachycardia it is the one with regular rhythm, right? And ventricular tachycardia presenting for 24 hours, the patient will not survive. Okay, so VT cannot be for 24 hours. All right, so VT can be ruled out. So the answer here is the atrial fibrillation. Next question. A 74-year-old woman presents with breathlessness. She is found to have elevated JVP. Which of the following condition is most likely to explain this physical finding? Aortic stenosis, dehydration, exacerbation of asthma, increased left atrial pressure, then recurrent pulmonary embolism. So there is like elevated JVP. So elevated JVP means there should be increase in the right ventricular pressure, or there should be increase in the right atrial pressure. Only when the JVP can be elevated. Now, among the options which has been given to you, which is the condition where the right ventricular or right atrial pressure will be elevated? That will be in case of recurrent pulmonary embolism. So in recurrent pulmonary embolism, initially there will be increased afterload on the right ventricle. So right ventricular pressure increases, subsequently right atrial pressure increases, and subsequently the JVP increases. Okay, whereas in case of aortic stenosis and as well as increased left atrial pressure, there can be increase in your right ventricular pressure, but only when there is development of your left heart failure. And in case of dehydration, in fact, you will have decreased JVP and exacerbation of the asthma. See, asthma is another condition where you can have elevated JVP as a result of your cor pulmonale. But among the options which has been given to you, the best answer will be your recurrent pulmonary embolism, where there will be definite increase in your right ventricular pressure, subsequently right atrial pressure, and subsequently increase in the JVP. Next question. A 35-year-old man presents with the history of headache. He is noted to have a loud heart sound, second heart sound on auscultation. Which of the following pathologies could explain this condition or finding? Aortic incompetence, essential hypertension, mechanical mitral valve replacement, mitral incompetence, postural hypotension. So there is history of headache and as well as the loud second heart sound. So these 2 points, they are very much suggestive of the essential hypertension, because in case of aortic incompetence, so aortic incompetence is nothing but your aortic regurgitation, and in case of the aortic regurgitation, the A2 will be absent, right? Whereas in case of the mechanical mitral valve replacement, so you will have the metallic sound, right? You will have the metallic sound. Whereas in case of the mitral incompetence, which is nothing but the mitral regurgitation, so in case of mitral regurgitation, you will have soft M1, right? You will have soft M1. Okay, so the one where you will have headache in case of the hypertension will be, it is mainly the occipital headache, right? It is mainly the occipital headache. So the answer in this question is essential hypertension. Coming on to the next question. A 55-year-old man with type 2 diabetes mellitus presents with 1 hour history of severe chest pain. Which of the following statements is true? A normal baseline troponin and elevated 6-hour troponin level is suspicion of the myocardial infarction. Second option, a normal ECG excludes myocardial infarction. Third option, a normal initial troponin level excludes MI. Failure of chest pain to resolve the nitrates confirm myocardial infarction. T-wave inversion on the ECG confirms the myocardial infarction. So diabetes mellitus, 1 hour history of chest pain, and 55 years man. So how can you confirm the myocardial infarction is a normal baseline troponin and elevated 6-hour troponin level is very much suggestive of the myocardial infarction. That's a true statement. So because the troponin, it will take nearly around 2 to 4 hours to get elevated. So you need to check the baseline troponin and elevated 6-hour troponin. That will definitely confirm the myocardial infarction. Whereas normal ECG excludes the myocardial infarction is a wrong statement, because in early stages of, or in early minutes or early hours of MI, the ECG may be normal, where you will not have any changes. And the troponin to be elevated, it takes almost 2 to 4 hours. So normal initial troponin excludes the myocardial infarction. That is also a wrong statement. And failure of chest pain to resolve with nitrates confirms the myocardial infarction will also be wrong statement, because in certain diabetic autonomic neuropathies, you don't have chest pain at all. And T-wave inversion on the ECG confirms myocardial infarction is a wrong statement, because T-wave inversion can be there in asymmetrical T-wave inversion can be there in strain pattern, in left ventricular hypertrophy, hypertrophic obstructive cardiomyopathy, raised intracranial pressure, right? So in all these conditions, the T-wave can be inverted. So T-wave inversion in the ECG does not represent the myocardial infarction. So the answer will be A, first option. Moving on to the next. So we have like what exactly is the underlying pathophysiological changes in chronic cardiac failure associated with activation of RAS, inhibition of sympathetic nervous system, reduced production of brain natriuretic peptide, systemic vasodilatation. So in patients with the chronic cardiac failure, there will be decreased cardiac output. So once there is decreased cardiac output, what will happen to renal perfusion? There will be decreased renal perfusion, and that will cause the activation of RAS, right? Number 2, there will be activation of the sympathetic nervous system, right? And there will be increased production of, right? There will be increased production of the atrial natriuretic peptide. Okay, so these 3 are the pathophysiological changes that you will have in patients with the chronic cardiac failure. So the answer will be the activation of renin, angiotensin, aldosterone system. And these compensatory mechanisms, they try to increase the blood pressure of the individual, but these compensatory mechanisms in long term, they will harm the heart. Okay, they will cause cardiac remodeling. So these compensatory mechanisms, they have to be inhibited in long term. Next question. Loop diuretics such as furosemide and bumetanide have which of the following effects? First option, diuretic due to inhibition of potassium and water reabsorption. Diuresis due to inhibition of the sodium and water reabsorption. Diuresis due to inhibition of water reabsorption only. Fourth option, increased serum potassium level due to enhanced distal tubule function. Fifth option, osmotic diuresis. Okay, so the furosemide, which is a loop diuretic, and bumetanide, which is also a loop diuretic, will cause diuresis due to inhibition of sodium and water reabsorption at the level of thick ascending limb of loop of Henle. Okay, the osmotic diuresis, it is caused by mannitol, whereas thiazide diuretics, they will inhibit the co-transporter, that is sodium chloride co-transport right? Sodium chloride co-transport at the level of the distal convoluted tubule. So the answer in this question is B. So the next question is, a 75-year-old woman has a history of hypertension and diabetes. She presents with atrial fibrillation. So what is her CHA2DS2 VAS scoring system? So CHA2DS2 VAS scoring system is the scoring system which is used in case of atrial fibrillation to decide whether to give antiplatelets or to give the anticoagulants. We give antiplatelets if the score is like 0 to 1, and if the score is like more than or equal to 2, then the anticoagulant should be given in patients with the atrial fibrillation. And the CHA2DS2 VAS scoring system, right? So this is what is your CHA2DS2 VAS scoring system. So your C stands for your congestive heart failure, give a score of 1 point, hypertension 1 point, age more than or equal to 75 years, then 2 points, diabetes 1 point, stroke 2 points, vascular disease 1 point, age more than or equal to 65 years 1 point, female gender 1 point. So our patient is a 75-year-old female patient. So 2 points are there because age is 75, and female 1 point, and she is also hypertensive, right? 1 point, and she is also diabetic, okay, and 1 point. So how much it becomes? So totally it comes to 5 points. Right, totally it comes to around 5 points. Okay, next question. So the answer here is the 5 points, right? Then you see the next question. The ECG below shows regular narrow complex tachycardia in a patient presenting with sudden onset rapid palpitations. Which of the following should be used first in attempting to terminate this rhythm? Direct current cardioversion, intravenous adenosine, intravenous beta blocker, oral beta blocker, vagal maneuvers, that is nothing but your Valsalva. Okay, so actually ECG was not able to be given because in the telegram we cannot post the images, but the regular narrow complex tachycardia in a patient presenting with sudden onset palpitations. So what is that we need to suspect is paroxysmal supraventricular tachycardia. Okay, the ECG what I just wanted to show you is the PSVT. So which of the following should be used first in attempting to terminate this rhythm? That is the vagal maneuver, which is nothing but your Valsalva. And if this particular vagal maneuver fails, then the drug of choice for acute attacks will be adenosine, right? And even with adenosine, if the narrow complex tachycardia is not being terminated, then we need to give non-dihydropyridine calcium channel blockers, that is diltiazem or verapamil should be given, right? Diltiazem or verapamil should be given. So the answer is E in this question. Then next question, which of the following is true of the Eisenmenger syndrome? Breathlessness and fatigue are uncommon symptoms. It occurs in patients with patent foramen ovale. Left to right shunting occurs because of pulmonary hypertension. Life expectancy is markedly reduced. Patients are peripherally but not centrally cynosed. So the answer in this question is life expectancy is markedly reduced. So in patients with Eisenmengers, what is Eisenmengerization? Eisenmengerization is seen in case of either ASD or ventricular septal defect, or in case of the patent ductus arteriosus. So in case of ASD or VSD or patent ductus arteriosus, the shunt will be from left to right initially, and later the shunt, it turns to right to left. Right, later the shunt turns to right to left, and this is what is called as the Eisenmengerization. And when will this occur is, this will occur whenever there is development of the pulmonary hypertension. So life expectancy is markedly reduced whenever there is development of the pulmonary hypertension. And whenever there is pulmonary hypertension, what will be the common symptom is the breathlessness and as well as the fatigue. These are the common symptoms in case of your the Eisenmengers. And it occurs in patients with patent foramen ovale is a wrong statement. It occurs in patients with the ASD. It occurs in patients with VSD. It occurs in patients with the patent ductus arteriosus. Okay, and left to right shunting occurs because of the pulmonary hypertension is wrong statement. So pulmonary hypertension will cause right to left shunting but not left to right shunting. And patients are peripherally cyanosed is wrong statement. These patients, they have the central cyanosis in case of the Eisenmenger syndrome. So the answer in this question is D, where the life expectancy is markedly reduced in these patients. Next question. What is the appropriate initial treatment for the symptoms of the acute pericarditis? Intravenous glucocorticoids, intravenous morphine, oral amiodarone, oral aspirin, rectal diclofenac. See, in case of the acute pericarditis, right, you need to give the anti-inflammatory drugs, that is, the aspirin is being given. And that too, like we give the high dose of the aspirin. And other non-steroidal anti-inflammatory drugs such as diclofenac can also be given orally. If at all, if you want to give diclofenac, not rectally, oral diclofenac can be effective. And steroids, are they useful? Yes. So, but the usage of the steroids is rare in cases of the acute pericarditis. We don't use this very frequently. Whereas amiodarone, this is an anti-arrhythmic drug. Okay, and this particular morphine is used mainly to reduce the pain in case of the myocardial infarction. Okay, so the answer in this question is the oral aspirin. Next question. Which of the following is the cause of dilated cardiomyopathy? A high cholesterol diet, heavy alcohol consumption, mutation in cardiac sodium channel gene, obesity, recreational cannabis use. So the one which can cause dilated cardiomyopathy is the heavy alcohol consumption, whereas you take the high cholesterol diet causing the hypercholesterolemia. So what this can lead to? This can lead to the development of the coronary artery disease but not the cardiomyopathy. And mutation in the cardiac sodium channel gene, that is associated with the development of the cardiac arrhythmias. Right, that is associated with the development of the cardiac arrhythmias, right? And this cardiac arrhythmias, they cause long QT syndrome, right? They cause long QT syndrome, or there can be development of the Brugada syndrome. Right, long QT syndrome or the Brugada syndrome. So that will be the problem because of sodium channel defect. And then next is the obesity. See, obesity, it is associated with the risk of development of the hypertension and as well as development of the type 2 diabetes mellitus, but it does not cause your cardiomyopathy. And your cannabis use, the recreational cannabis use, it is also the one which is associated with the coronary artery disease. Okay, so the one which can cause dilated cardiomyopathy is the heavy consumption of alcohol. Next question. Cardiac transplantation is considered in which group of patients with cardiomyopathy? Asymptomatic patients, frail elderly patients with end-stage heart failure, patients who do not wish to take lifelong medication. Fourth option, patients who have poor quality of life despite optimal drug therapy. Fifth option, patients who have symptoms but good quality of life on optimal drug therapy. So the answer in this question is patients who have poor quality of life despite optimal drug therapy. Okay, so please remember, cardiac transplantation is limited by the availability of the donor organs, the need for lifelong immunosuppressive therapy to prevent the rejection. So these are the two important limitations. One, the donor availability is not like that frequent. Number two, like lifelong, these patients, they have to take the immunosuppressive therapy, and because of that, usually the cardiac transplantation is being avoided. Now, the cardiac transplantation should be done in those individuals in whom where you have given optimal drug therapy, but still there is like the patient is symptomatic and the individual is having poor quality of life. Asymptomatic patients, why do you want to do cardiac transplantation? Not required, right? And elderly patients, we don't do cardiac transplantation because the life expectancy in an elderly individual is less. So usually in elderly patients, we avoid the cardiac transplantation. And who do not wish to take lifelong medications? No, because after cardiac transplantation, again, the individual has to take the immunosuppressive therapy lifelong. So who do not want to take medication in them, we don't do the cardiac transplantation. who have symptoms but good quality of life. When there is good quality of life, usually the cardiac transplantation is avoided. So the answer is patients who have the poor quality of life despite optimal drug therapy. Next question. Which of the following is associated with excessive alcohol consumption? The options are atrial fibrillation, diverticulitis, hypertrophic cardiomyopathy, hypotension, supraventricular tachycardia. So the one with associated with alcohol consumption is the atrial fibrillation. So the cardiac effect of the alcohol, if you observe, there are two important things. One is development of dilated cardiomyopathy, and second important is the holiday heart syndrome, development of the atrial fibrillation. So these are the two cardiac effects of the excessive alcohol consumption. And not only that, this excessive alcohol, this can also cause the liver disease in the individual. Then it can also cause pancreatitis. Alcohol can also cause the hypertension, and it can also cause the cognitive dysfunction. Right? It can also cause the cognitive dysfunction. So these will be the adverse effects associated with the alcohol. These will be the adverse effects associated with the alcohol. So atrial fibrillation is the one which can be associated with this excessive consumption of alcohol. Next question. Atrial myxoma is the most common primary cardiac tumor. Which of the following is true of the atrial myxoma? Atrial myxomas are usually malignant. It occurs more commonly in right than compared to that of left. Surgery is not indicated because atrial myxomas are benign. Surgery is usually indicated to prevent the embolic complications such as stroke. The tumor commonly obstructs the aortic valve. So in case of the atrial myxomas, the surgery is usually indicated to prevent the embolic complications such as stroke. And if you take the first option, atrial myxomas are usually malignant, is a wrong statement. So most of these atrial myxomas, they are the benign tumors, and it occurs more commonly in the right atrium. That is a wrong statement. They occur most commonly in the left atrium than compared to that of the right atrium. And surgery is not indicated is a wrong statement. Surgery has to be done in these individuals mainly to prevent the embolic complications. And the tumor commonly obstructs the aortic valve. That is also a wrong statement because usually the tumor, it obstructs the mitral valve, not the aortic valve. Okay, next question. In patients with pericardial effusion, what is the most important clinical sign to determine whether there is cardiac tamponade? Stenosis, hematuria, peripheral edema, pulsus paradoxus, raised jugular venous pressure. Okay, so the one which tells you that the patient is having the cardiac tamponade is the pulsus paradoxus. Pulsus paradoxus, it is present in case of the cardiac tamponade but absent in patients with the pericardial effusion. Whereas you take the raised JVP. Raised JVP can be there even in cardiac tamponade and as well as the pericardial effusion also, right? But the pulsus paradoxus is present only in case of cardiac tamponade. Next question. The following medical treatments are all associated with improved symptoms in patients with heart failure due to left ventricular systolic dysfunction. However, which of the treatment has not been shown to also improve the survival of the individual? So bisoprolol, enalapril, furosemide, sacubitril, valsartan, spironolactone. See, the drugs which will improve the survival in case of the heart failure is like the ACE inhibitors or the angiotensin receptor blockers. Then we have aldosterone antagonists, right? So these aldosterone antagonists, they include spironolactone and as well as the eplerenone. Then your ARNI, that is angiotensin receptor blocker, neprilysin inhibitor, which is nothing but sacubitril valsartan. Then we have SGLT2 inhibitors. What are the examples of your SGLT2 inhibitors? That is dapagliflozin, empagliflozin and canagliflozin. So these SGLT2 inhibitors also will improve the survival. And among the options, the one which, and one more important group of drugs will be your beta blockers. They also improve the survival and reduce the mortality. So among the options which has been given to you, the one which will not improve the survival will be your furosemide. Furosemide, it is only required for symptomatic management of your pulmonary edema in case of heart failure, but it does not reduce the mortality in the patients. All right, next question. So the neuroendocrine system activation is a feature of the heart failure. Abnormalities of which hormone can cause the heart failure rather than result from the heart failure? The aldosterone, angiotensin II, catecholamines, thyroxine, vasopressin. So in case of the heart failure, there is activation of RAS. So your aldosterone and angiotensin II will be produced as a part of the compensatory mechanism. And there is also increase in the sympathetic nervous system. So catecholamines are also being produced in heart failure as a compensatory mechanism. And there is non-osmotic release of antidiuretic hormone. Even vasopressin is also released in case of your heart failure as a part of the compensatory mechanism. But you take the answer is thyroxine. So thyroid hormones, they are generally unaffected in case of the cardiac failure. But if there is increase in the thyroid hormone levels or if there is decrease in the thyroid hormone levels, both of them, they can cause the heart failure. Right, both of them, they can cause the heart failure. So the answer in this question is D. Then moving on to the next question. A patient admitted to the emergency department with severe chest pain and ST segment elevation suddenly collapses and is found not to be breathing or having a pulse. A cardiac arrest call is made. What is the most likely cause of his collapse? Asystole, complete heart block, free wall rupture, pulseless electrical activity, and then the ventricular fibrillation. So immediately after the myocardial infarction, what are the anticipated electrical complications? So there are two things. One is electrical complications and the other one is structural complications immediately after myocardial infarction. So the electrical complications which are associated immediately after MI will be your tachyarrhythmias. Now what will be the tachyarrhythmias? This tachyarrhythmias will be ventricular tachycardia or ventricular fibrillation, and there can be also bradyarrhythmias, and these bradyarrhythmias will be in the form of the complete heart block. Okay, so the one which is most common responsible for sudden cardiac death is the ventricular fibrillation. And even there can be structural complications in patients with the myocardial infarction. So what will be the structural complications? The structural complications which are being associated are, they include the ventricular septal defect, mitral regurgitation, and then the cardiac free wall rupture. Right, the cardiac free wall rupture. So these are the structural complications, right? But among this, the one which is most common and will be responsible for sudden collapse immediately after MI will be your VT or the VF. So the answer in this question is the ventricular fibrillation, right? And the other conditions where you can have the other complications where you can have like sudden cardiac death is even your free wall rupture. Even free wall rupture can cause the cardiac arrest in the individual. But in between your VT and VF and the free wall rupture, the most common is your ventricular fibrillation is most common. Next question. Now, a 65-year-old smoker with hypertension is found to have abdominal aortic aneurysm on population screening with ultrasound. Which intervention will most reduce his future risk of development of aortic aneurysm rupture? ACE inhibitors, beta blockers, smoking cessation, statins, and warfarin. The answer here is the smoking cessation. See, your beta blockers and as well as ACE inhibitors, both of them, they will reduce the arterial wall stress. Right? Both of them, they reduce the arterial wall stress. Right? And these drugs, that is beta blockers and ACE inhibitors, if they are reducing the arterial wall stress, that is very good. They will reduce the risk of the aortic aneurysm expansion and as well as the rupture. And the same way is your statins also. Statins also will reduce the rate of progression of the atherosclerosis. Right? Will reduce the rate of progression of the atherosclerosis. So once there is reduced rate of progression of atherosclerosis, please remember there will be reduced risk of rupture through cholesterol dependent and cholesterol independent effects, right? And but between your ABCD option, among all these interventions, ABCD, all of them, they will reduce the risk of aortic aneurysm rupture. But among all these interventions, the greatest effect is in reducing the risk of aneurysm rupture is the smoking cessation. Okay, that is most important. Next question. A 50-year-old woman with diabetes who smokes presents with the jaw pain, severe nausea, autonomic arousal and vomiting. An ECG is performed in the emergency department and shows anterior ST segment elevation. What is the best immediate reperfusion therapy? So the question is very clear. What is the best immediate reperfusion therapy? CABG, morphine, PCI, primary PCI, streptokinase, tissue plasminogen activator. So if the question is asked like what is the first line treatment in this patient, that would be the aspirin. But the question is asked very clearly, the best immediate reperfusion therapy. So there are three methods by which you can do reperfusion in case of MI. One is your PCI. Second is coronary artery bypass graft, right? And third is by your thrombolysis. Right? Third is by your thrombolysis. So these are the three methods by which you can do the reperfusion therapy. Out of which is best? That is, the primary PCI is being best. So because it will cause 100% revascularization and we can do a minimally invasive procedure, right? So primary PCI will be the best. Next question. An 18-year-old woman presents with a sore throat and suspected acute rheumatic fever. Which of the following is a minor manifestation of the acute rheumatic fever? The options are carditis, chorea, erythema marginatum, raised C-reactive protein, subcutaneous nodules. So the question asked is like minor manifestations. Carditis, chorea, erythema marginatum and subcutaneous nodules. These are the major manifestations. And one more important major manifestation is polyarthritis. So polyarthritis, it is actually the earliest and as well as the common major manifestation in case of acute rheumatic fever. But you take the minor manifestation. Minor manifestation of acute rheumatic fever will be raised C-reactive protein. And what are the other minor manifestation is C-reactive protein is elevated, then ESR is being elevated, then followed by that the PR interval will be prolonged. So these will be the minor manifestation and even the presence of fever. So these are, and even the presence of arthralgia. So these are right, these are the minor manifestations in case of the acute rheumatic fever. Next question. So a 34-year-old woman presents with symptoms of breathlessness on exertion, a malar flush and has a past history of rheumatic fever. She is in sinus rhythm and has an echocardiogram that confirms the mitral stenosis. Which physical sign is she likely to have? The ejection systolic murmur, mid-systolic murmur, pre-systolic accentuation, quiet second heart sound, thrusting apex beat. Okay, so what is this particular patient having? This patient is having the mitral stenosis. So in case of the mitral stenosis, the one that you will have is the pre-systolic accentuation. So first and foremost, they'll have loud first heart sound, right? And in systole, you don't listen anything. And you take S2. In the S2, they'll develop in severe pulmonary in severe mitral stenosis, they can develop pulmonary hypertension, because of which there will be loud P2. And again in the diastole, in the early part of the diastole, you will have the opening snap. In the mid part of the diastole, you will have mid-diastolic murmur, and in later part of the diastole, you will have pre-systolic accentuation. And where do you get this ejection systolic murmur? You get this in case of the aortic stenosis, pulmonary stenosis, and as well as the HOCM. And mid or ejection systolic click. This is also heard in aortic stenosis and pulmonary stenosis. And quiet second heart sound. See, second heart sound is like quiet or soft in case of the aortic stenosis or pulmonary stenosis, aortic regurgitation and pulmonary regurgitation. Okay, so thrusting type of apex beat, like it is like hyperdynamic type of apex beat. You see that in patients with the aortic incompetence or the aortic regurgitation. Okay, so the answer in this question is pre-systolic accentuation, and this pre-systolic accentuation, this is due to strong left atrial contraction, right? Strong left atrial contraction in patients with mitral stenosis. Okay, so that is your question number 22. Then you take question number 23. An 80-year-old man presents with an incidental ejection systolic murmur. His family physician notices a parasternal thrill What is the likely underlying reason for the thrill? The options are aortic stenosis, large atrial septal defect, mitral stenosis, pulmonary hypertension, then right ventricular hypertrophy. So this particular patient is like 80-year-old individual, ejection systolic murmur, parasternal thrill. So 80-year-old individual with ejection systolic murmur, what is that suspicion is the presence of the aortic stenosis. So in aortic stenosis, you also have right parasternal thrill as well. And your thrill is nothing but your palpable murmur. Whereas in case of large atrial septal defect, these patients can develop the pulmonary hypertension, right? And usually in case of ASD, you don't have any murmur, but there can be the functional murmur. And that functional murmur will be like in the form of the functional pulmonary stenosis. And even this can also cause ejection systolic murmur. But if it is a functional murmur, you don't have a thrill. Next, in case of mitral stenosis, the murmur will be mid-diastolic murmur. It is not ejection systolic murmur. Okay. And in pulmonary hypertension, you can have a functional murmur, and that is nothing but the Graham-Steele's murmur, right? And this Graham-Steele's murmur, okay, it is like pulmonary regurgitation, and that will be the early diastolic murmur. That is what you will have in case of the pulmonary hypertension. And right ventricular hypertrophy can be the consequence of your pulmonary hypertension or pulmonary stenosis. So the answer in this question is the aortic stenosis. Next question. Considering the patient with infective endocarditis, before the blood culture results are known, the junior doctor reviews the 65-year-old man and examines him for evidence of endocarditis. What is the commonest sign that the doctor is likely to find? Hematuria, Osler's nodes, Roth spots, splinter hemorrhages, and subconjunctival hemorrhages. The answer in this question is the hematuria. Now, if you take these options like Osler's nodes, then followed by that splinter hemorrhages and the subconjunctival hemorrhages, okay, they are not seen in most patients of the infective endocarditis. But if at all, if this Osler's nodes, splinter hemorrhages, and subconjunctival hemorrhages are present, it is suggestive of infective endocarditis. But they are not seen in most patients of infective endocarditis. Whereas Roth spots, it is like fundoscopy finding, where you have, right, where you have the retinal hemorrhages. And even the Roth spots, they are uncommon in patients with the infective endocarditis. So among all these options, the commonest manifestation of the endocarditis will be hematuria, right? The option is A. Answer is A. Next question. So an army recruit is referred for assessment because there is family history of sudden cardiac death, and an uncle was diagnosed with hypertrophic cardiomyopathy. In what manner is a hypertrophic cardiomyopathy commonly inherited as? Autosomal dominant, autosomal recessive, never inherited, X-linked dominant, X-linked recessive. So remember, it is dominant inheritance, but it is autosomal dominant type of inheritance. That is what you will observe in case of the hypertrophic cardiomyopathy. And next important point in case of the hypertrophic cardiomyopathy is you need to know what is the most common gene that is being mutated. That is, the beta myosin gene is being mutated, and this beta myosin gene, it is present on the chromosome number 14, right? It is present on chromosome number 14, and the mutation of this beta myosin gene, it is inherited as an autosomal dominant type of inheritance, right? And the other proteins which are being defective is the troponin T, right? And the other proteins are myosin binding protein C. So these are the proteins which are being defective, and the type of inheritance will be autosomal dominant type of inheritance. Next question. A patient presents with an incidental finding of a mass in the left atrium whilst undergoing an echocardiogram for hypertension. What is the most likely cardiac tumor in this situation? Angiosarcoma, atrial myxoma, fibroelastoma, fibroma, and then lipoma. So as just now we have discussed in the previous question also, that is the atrial myxoma, that is the most common tumor, most common cardiac tumor, and this is a benign tumor, right? This is a benign tumor, and it is more commonly present in the left atrium than compared to that of the right atrium, okay? And these patients with atrial myxomas, they are at increased risk of the embolism, right? They are at increased risk of the embolism. So the answer in this question is the atrial myxomas. Coming on to the next question, that is, a 43-year-old man has an extensive anterior wall MI and has received antiplatelets, anticoagulants, and statin therapy. He is referred for an echocardiogram. What will transthoracic echocardiography most usefully assess in this setting? The options are cardiac arrhythmias, future prognosis, left ventricular function and the presence of the mural thrombus, myocardial scar formation, presence of thrombus in the left atrium. So the question is like, what will transthoracic echocardiography most useful in assessing in this setting of the anterior myocardial infarction? So the answer is the 2D echo. It is useful for assessment of the left ventricular function, right, and the presence of the mural thrombus. Okay, because once there is left ventricular dysfunction, there can be stasis of the blood resulting in the formation of the thrombus. Okay, whereas the cardiac arrhythmias, that can be assessed by ECG but not by the echocardiography. All right, then you take the future prognosis. Echocardiography gives limited information about the prognosis, right? It gives limited information about the prognosis and the presence of the myocardial scar. See, the presence of the myocardial scar, it is not being demonstrated by your echocardiography, but it is your MRI of the heart that can demonstrate the presence of the myocardial scar. And thrombus in the left atrium, yes, that can be demonstrated by your echocardiography. But the point is, in case of the myocardial infarction, there is more chances of development of your thrombus formation within the ventricle rather than the atria. Okay, so left ventricular function and presence of the mural thrombus assessment is the best answer, which is being done by your transthoracic echocardiography in a patient with myocardial infarction. Next question. An 83-year-old woman presents with acute pulmonary edema. Blood pressure is 180 by 100 millimeters of mercury. Saturation of 85%. Which treatment is unlikely to be helpful in this setting? Furosemide, intravenous dobutamine, intravenous nitrates, non-invasive ventilation, supplementary oxygen therapy. So the patient's blood pressure is almost like 180 by 100 and saturation is 85%. And patient is in a state of acute pulmonary edema. So definitely the furosemide is very much important. That will clear the pulmonary edema. And intravenous nitrates, they are also useful because these intravenous nitrates, they reduce, right? They reduce the preload. And not only that, the nitrates will also reduce the afterload. And non-invasive ventilation, definitely it is very much useful because this non-invasive ventilation, that is positive pressure ventilation, will clear the edema from the alveoli into the peripheral circulation. And supplemental oxygen therapy is also very much required. But the one which is not required here is the intravenous dobutamine. That is not required in case of a patient with blood pressure of almost 180 by 100. Okay, next question. An anesthetist is seeking advice regarding a patient with the coronary heart disease, diabetes mellitus, and a murmur. Which of the following is not a significant risk factor for perioperative myocardial infarction during non-cardiac surgery? The options are aortic stenosis with peak gradient of 25 millimeters of mercury, then diabetics treated with insulin and associated with renal failure, recent stenting of severe proximal stenosis in left anterior descending artery, recent acute coronary syndrome, and severe left ventricular dysfunction. So the question says, which of the following is not a significant risk factor for perioperative myocardial infarction during non-cardiac surgery? So please remember, surgery, it is associated with the activation of the platelets. Right, it is associated with activation of the platelets and it will also activate the coagulation pathway. Right, it will also activate the coagulation pathway. So both of these, they can they can precipitate the thrombus formation within the stent, and they can also precipitate the recent acute coronary syndrome. And you take this diabetes mellitus and as well as the renal failure. So insulin treated diabetic patients and as well as those with renal failure may have occult coronary artery disease, and this occult coronary artery disease, the risk increases in the perioperative myocardial infarction state. Okay, the risk is definitely increased. So your B, C, D, and even your severe left ventricular dysfunction, you cannot do a non-cardiac surgery at all because that will increase the risk. Okay, so aortic stenosis with a peak gradient of 25, is not a significant risk factor for perioperative myocardial infarction during non-cardiac surgery. See, when there can be risk in case of the aortic stenosis is when the gradient is like more than 40, where there is severe aortic stenosis. In such case, there can be a perioperative risk. But at a gradient of 25, it is not a risk. So the answer is A, right? The last question in the cardiology. You review a 50-year-old smoker 2 months after successful treatment for a myocardial infarction. Which intervention has the greatest benefit to prevent a recurrence of the myocardial infarction? ACE inhibitors, aspirin, regular and frequent aerobic exercise, smoking cessation, and as well as the statin therapy. So, which intervention? The greatest benefit, that will be the smoking cessation. That is the strongest risk factor for the development of coronary artery disease. Which one? The smoking. So, the lifestyle modification, that is smoking cessation, makes the largest difference to the cardiovascular risk. So, the answer is the smoking. Otherwise, aspirin, it also helps. Statin therapy also helps. Aerobic exercise also helps. But among all these, the best answer would be your smoking cessation. So these are the questions on the cardiology in the grand test which has been conducted on 6th of December 2023, right? Thank you very much, and I will discuss the connective tissue disorders in the next video.